Hi everyone, our subject today is obesity in pediatrics. Basics. Excess adiposity correlates closely with the increased health risk for multiple medical and psychosocial disorder. Body mass index BMI is an easily obtained clinical measure to assess for increased body fat and concomitant health risk. Body mass index is calculated as weight in kilogram divided by height in meters squared. In children, age and sex specific percentile define obesity. For children 2 years and above of age, body mass index is overweight when it is 85%. Body mass index if it is less than 98% or over 30 is considered obese. More than or equal to 99% is severe obesity. Body mass index reference standards are not available for children less than 2 years of age. In this age group, overweight is defined as weight for length equal or more than 95% for the age and sex. History. Birth history, birth weight, maternal gestational weight gain, gestational diabetes, growth history, weight trajectory, and age where percentile were crossed. Medical and or social stressor, medical history, asthma, medication, obesity, comorbidities, motivation, parental concern and desire for change and willingness to modify family's behavior, child's concern and motivation as age appropriate, family history, obesity, diabetes, cardiovascular disease, dyslipidemia, eating disorder, dietary history, sugar sweetened beverage consumed, frequency of fruit and vegetables, frequency and type of snack food, frequency of fast food, eating behavior, family meals, TV viewing during meals, recognition of satiety, binge eating with or without loss of control, physical activity, total screen time including phone and handheld device, duration, intensity and frequency of physical activity, sleep duration and pattern, previous attempt at weight loss, medication use, prescribed or over-the-counter, weight loss program, review of system, headache could be pseudotumor cerebri, snoring, pauses in breathing, daytime somnolence could be obstructive sleep apnea, abdominal pain due to could be reflux or gallstone, joint pain could be hip pain, slipped capital femoral epiphysis, social isolation, emotional eating, behavioral difficulties, maybe depression, skin color changes, acanthosis nigricans, polydipsia, polyuria, could be diabetes, irregular menses, amenorrhea, could be polycystic ovarian syndrome. Physical examination, anthropometric weight, height, body mass index, and body mass index percentile, blood pressure for age, sex, and weight, height percentile, general physical findings suggestive of endocrine or genetic condition like short stature, dysmorphic faces, developmental delay, head, ears, eyes, nose, throat, papilledema, tonsillar hypertrophy and narrow pharyngeal opening, cardiopulmonary, poor aeration, wheezing, heart murmur, abdomen, hepatomegaly, abdominal pain, genitourinary, Tanner stage, musculoskeletal, range of motion at hip, abnormal curvature of lower leg, limb, skin acanthosis nigricans, hirsutism, striae, psychosocial mood, assess for evidence of depression, bullying, social isolation. How to approach to child with obesity after performing history and physical examination. Is there drug use, obesogenic medication or drugs? If it is yes, could be antipsychotic like risperidone, phenothiazine, a tricyclic antidepressant, lithium, anticonvulsant, valproate, carbamazepine, antihistamine, cyproheptadine, anti-diabetic drug like insulin, sulfonylurea, exogenous steroid, beta-adrenergic blocker like propranolol, steroid, hormone like progestins. If there is no medication, is there sign and symptom suggestive of underlying medical condition like short or excessive stature, dysmorphic feature, pubertal delay, menstrual irregularity, hirsutism, developmental delay, intellectual disability? If it is no, there is no of these criteria. No, is there if the patient meet criteria of an eating disorder? If it is yes, refer for psychiatric. This is could be bulimia or binge eating disorder. Or no, if there is no criteria for eating disorder, this is primary obesity. If the patient has a sign of symptoms suggestive of underlying medical condition or any of these, if there is short stature or pubertal delay, consider a free T4, TSH, insulin like growth factor 1, insulin like growth factor binding protein 3, karyotype, referral to genetics or endocrinology. Differential diagnosis: hypothyroidism, growth hormone deficiency, hypothalamic dysfunction, Prader-Willi syndrome, and Turner syndrome. Also, if there is one of these, is there dysmorphism, developmental delay, intellectual disability, short stature, genetic counseling, karyotype? Differential diagnosis: Prader-Willi syndrome, Turner syndrome, Lawrence-Moon-Vidal syndrome, Elstrom-Hallgren syndrome, Carpenter syndrome, Albright hereditary osteodystrophy, Cohen syndrome, bimodal syndrome, and gene disorder. Continuation of these, if there is dysmorphic or other feature. Is there short stature, striae, hypertension, truncal obesity, buffalo ham? Patient need late night salivary cortisol, urine-free cortisol, 24-hour urine steroid, and serum cortisol. This is Cushing syndrome. If there is oligomenorrhea, amenorrhea, hirsutism, patient needs DHEAS, free testosterone, LH, FSH. This could be polycystic ovarian disease. Is there hypoglycemic symptoms, hyperphagia, normal or increased stature? Refer for endocrinology. Differential diagnosis: hyperinsulinism, insulinoma, diabetes mellitus, excess insulin administration, and melanocortin 4 receptor gene mutation. Clinical peers. Obesity implies increased body fat and not weight. Body mass index may erroneously diagnose obesity in short muscular individual. Childhood obesity is most commonly due to lifestyle factor. Think of pathological obesity in children with the growth failure and or developmental delay. Constitutional obesity is more likely if the child is tall and fat. Lipomastia may look like telarchy. Bird penis in suprapubic fat may give false impression of micropenis in obese boy. Lifestyle measures should be adopted by entire family, not just the child. Medical and surgical treatment of childhood obesity should be considered only in severe cases associated with complication. Management is difficult. Prevention is critical at all levels, from individual to social. Childhood obesity is now a global epidemic, mainly due to lifestyle changes. Pathological causes are more rare. Obesity leads to several health problems. It should be taken seriously. Most obese children require investigation not for the cause, but for the consequences of obesity. A common reason for seeking medical help for child's obesity is parental concern about whether the child's glands are normal. Obesity usually does not have glands as an underlying cause. Top tips. As body mass index gives no indication of the body fat distribution, waist circumference midway between the 10th rib and the top of the iliac crest is a marker for central body fat accumulation and is more accurate than body mass index. Much time is wasted in clinic by giving unwanted advice about food. The child with the obesity is aware of that and often upset by frequently hearing that he is or she eating too much. And dietary restriction is notoriously unsuccessful in treating the condition. The main cause of childhood onset obesity is not overeating but genetics, usually confirmed by a detailed family history, and decreased energy output. The latter can be estimated indirectly by total hours spent in front of television and computer per day. Red flag. Record blood pressure in any child with obesity. It is elevated in those with the constitutional obesity, Cushing syndrome and Turner syndrome, and may also be elevated in simple obesity sooner or later. Obesity may have child abuse, like neglect, as an underlying cause. If such a case is suspected, appropriate referral to appropriate service is essential. Complication of obesity: metabolic, like insulin resistant, type 2 diabetes mellitus, metabolic syndrome, and hyperandrogenism. Cardiovascular, hypertension, dyslipidemia, atherosclerosis. Gastrointestinal, non-alcoholic fatty liver disease, gallstone, gastroesophageal reflux. Skeletal, Blonnet disease, slip capital femoral epiphysis, fracture. Respiratory, obstructive sleep apnea, hypoventilation syndrome. Neurological, benign intracranial hypertension. In most cases, obesity is the result of positive energy balance that is stored as adipose tissue. Factors associated with the positive balance include excessive intake of high energy food, inadequate exercise, sedentary lifestyle, low metabolic rate, and inadequate sleep. In primary obesity, screening for comorbidities is recommended. Screening tests may include fasting glucose and hemoglobin A1C to screen for diabetes and pre-diabetes, serum ALT to screen for fatty liver, and lipid panel for hyperlipidemias. Vitamin D level may also be obtained. Vitamin D deficiency is commonly associated with obesity. Prader-Willi syndrome is associated with the transient neonatal hypotonia, developmental delay, and intellectual disability. There is a hypogonadotrophic hypogonadism and associated short stature. Feeding problems may occur during infancy, and extreme hyperphagia may occur in childhood and adolescence. The hands and feet are small. Strabismus is often present. Fish 15q11 microdeletion is present in 70% of cases. Turner syndrome should be considered in a short female, particularly if there is a history of pubertal delay and amenorrhea. Features of this syndrome include webbed neck, low posterior hairline, a small mandible, prominent ears, epicanthal folds, high arched palate, broad chest with a wide-spaced nubble, cubitus valgus, and hyperconvex fingernail. Diagnosis may be made by chromosomal analysis. Lawrence-Moon-Vidal syndrome is characterized by truncal obesity and retinal dystrophy retinitis pigmentosa with progressive visual impairment. Other features include intellectual disability, digital anomalies, polydactyly, syndactyly, hypogenitalism, and nephropathy. Alstrom-Hallgren syndrome is associated with the nerve deafness, diabetes mellitus, retinal degeneration with blindness, cataract, and small testes in male. Cohen syndrome is characterized by truncal obesity, hypotonia, muscular weakness, and mild intellectual disability. Characteristics craniofacial features include high nasal bridge, maxillary hypoplasia, down slanting palpebral fissure, high arched palate, short philtrum, strabismus, small jaw, open mouth, and prominent maxillary incisor. In addition, narrow hand and feet, short metacarpal and metatarsals, simian creases, hyperextension, extensible joint, lumbar lordosis, and mild scoliosis are often present. Carpenter syndrome is characterized by brachycephaly with craniosynostosis, lateral displacement of inner canthi and apparent exophthalmos, flat nasal bridge, low set ears, retrognathia, and high arched palate. The extremities may show brachydactyly, syndactyly, and polydactyly. Intellectual disability is present. Albright hereditary osteodystrophy, pseudohypoparathyroidism type 1, occurs as short stature, round face, short metacarpal and metatarsal, mental retardation, cataracts, coarse skin, brittle hair and nail, as well as hypocalcemia and hyperphosphatemia. Bimode syndrome present with cognitive impairment, coloboma of the iris, hypogonadism, and polydactyly. Gene disorder known to result in obesity include FTO, fat mass and obesity, and INSIG2, insulin-induced gene 2 mutation, leptin or leptin receptor deficiency, and pro-opiomelanocortin deficiency. Cushing syndrome is characterized by truncal obesity with the hypertension caused by high level of cortisol arising from adrenal cortex. Other features include moon face, plethora, hirsutism, buffalo ham, striae. Prolonged exogenous administration of corticotropin or corticosteroid can cause similar feature referred to as Cushingoid appearance. There may be signs of virilization, include hirsutism, acne, deepening of the voice, and clitoral enlargement in girls. Growth impairment occur except when significant virilization is present, resulting in a period of normal or increased growth. Delayed puberty, amenorrhea, and oligomenorrhea in girls past menarche may occur. Laboratory findings include elevated evening cortisol level, loss of normal diurnal rhythm with the decreased evening cortisol level, and increased urinary excretion of free cortisol and 17-hydroxycorticosteroid. The classic polycystic ovaries syndrome is characterized by obesity, hirsutism, and secondary amenorrhea with bilateral enlarged polycystic ovaries. Laboratory findings are variable. Total testosterone level is usually normal, but serum free testosterone level is often elevated and sex hormone binding globulin level decreased. There is often an increased ratio of LH to FSH. Dihydroepiandrosterone sulfate DHEAS level are normal or moderately elevated. Hyperandrogenism is often associated with the insulin resistance and acanthosis nigricans. Testing for hyperinsulinism, fasting blood insulin, and glucose may be considered in women with the persistent anovulation, android obesity, or acanthosis nigricans. Hypoglycemic symptoms, particularly with the rapid drop in glucose level, may be due to activation of the autonomic nervous system and include perspiration, tachycardia, pallor, tremulousness, weakness, hunger, nausea, and vomiting, with a slower decrease in glucose level or prolonged hypoglycemia. Symptoms include headache, confusion, and visual disturbance. The symptoms of hypoglycemia in infant may be or more subtle, such as cyanosis, apnea, hypothermia, hypotonia, or poor feeding, lethargy, and seizure. In older children, hypoglycemia may cause behavioral problems, inattention, ravenous appetite, or seizure. Hyperinsulinemia may be due to insulin-secreting pancreatic tumor, hypersecretion of the pancreatic beta cell, or hypothalamic lesion. There is hyperinsulinemia with the hyperphagia and increased linear growth. It may also be caused by excessive amount of insulin in patients with diabetes mellitus. Melanocortin 4 receptor gene mutation is the most common known genetic cause for obesity that is severe and early onset. Eating disorders are more common in females and among whites. Most patients first develop symptoms during adolescence. Bulimia nervosa and binge eating disorder are characterized by weight gain in contrast to anorexia nervosa. In binge eating disorder, a distorted body image is often present. Those affected may tend to eat alone and have feeling of guilt or disgust after binge eating. The hallmark of bulimia nervosa is binge eating followed by compensatory behavior such as purging, exercise, fasting, and laxative use. Thank you for your listening.